Today, I'm excited to be welcoming back Jeff Walter, DPT, NCS, an expert in all things vestibular. We'll be diving even deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mauder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome, Jeff.
Hi, JJ. I'm happy to be back. Always excited to talk about vestibular topics and hopefully facilitate some learning today.
Yes, you are. I love that. We're excited, too, to have you back on the show to share more about vestibular rehab. You were actually my very first interview. And I can tell you, it was the very first time I ever did this. And I can tell you that it was very popular. People loved it. So
It's good to hear.
Out there, the listeners, if you missed it, I would go back. It's episode number one. Since then, we've gotten a lot more requests for vestibular content and for you specifically as well. So we're really excited to have you back. And for those that may be hearing from you for the first time, I was wondering, can you go back and just share a little bit about yourself and how you're involved with vestibular rehab?
Sure. I work at Geisinger Medical Center, which is in central Pennsylvania. It's a large teaching hospital in a rural area of central Pennsylvania. I exclusively see patients that have dizziness or balance issues within an ENT department. So I work with otologists, audiologists, and myself and another physical therapist at our balance center. A little bit of administrative role, but mostly clinical practice. Then I have a strong interest in teaching, so that's kind of a side venture through MedBridge and live courses. And I also do research with some of our residents here in our department, so I kind of wear those different hats.
So you stay busy.
Yeah, very busy. I really like what I do. I just found this niche early in my career and really just fell in love with it. And I had no idea I'd be doing this when I entered physical therapy school, but it just became a passion of mine.
Isn't that funny? And it's so good for people to hear that because, they think they're going to want something, but there's so many other options out there.
Yeah, I
And
always tell people it's such a diverse field that, you can often find a niche that you can lock onto and enjoy and have a passion for because it's such a diverse field.
And I think you bring that out, in people when you're talking about it because you definitely love vestibular. And as I said in our first interview, it is not my strength. And so I know when we were going to have you back on, it's what do you think people want to know? And I'm always like, what kind of tips can we give them? And you're like, oh, I got that covered. I have some, you had a list. I have a list of clinical practice tips that I can go and just go through, and it will help many, many people, whether or not you're a vestibular expert or just treating people in general. And so knowing your extensive knowledge background of the research and your clinical experience, I was just kind of let you loose and stop and ask questions since it isn't my area of expertise, so that we can all kind of learn as we go along. What do you think of that idea?
That sounds great. Yeah. So we put together a list today, and kind of the goal was that these might be things that, especially if you only have a surface knowledge or casual knowledge of vestibular, that you might not be familiar with. So I wanted to hit on some teaching points for both evaluative examination purposes and treatment purposes of items that you may not be as aware of as other practice parameters within vestibular rehab.
Outstanding. I'm excited.
Good.
All right. You hit me. Hit me with
All
the
right.
first one.
So the first item we're going to talk about is what's called a Sidelying test. I think most occupational and physical therapists have heard of a Dix-Hallpike maneuver, and that's a very popular test to identify posterior canal BPV. a really viable alternative test to identify BPPV of the posterior canal, which is the most common variant of BPPV we see. So BPV can affect the horizontal canal, not very often the anterior canal. The posterior canal is kind of your sweet spot for it. So this has actually been the research on this was put out years and years ago, but I just still find that therapists aren't aware of it. And it's called a Sidelying test. And the advantage of a Sidelying test over a Dix-Hallpike is it's more suitable for patients with back pain. If you're in a home care setting where the bed's not as accessible, you could do it on a couch. You don't have to drop the patient's head over the edge of a bed to do it. If your patient gets short of breath with lying flat, being supine, it's an alternative because the patient's never in a supine position for the test. They're in a Sidelying position, so it's more comfortable for them. It actually requires less effort on the part of the examiner. It works well if you're in a clinic with a short treatment length. So those are the advantages to it. The major disadvantage to this alternative test for identifying BPPV is it's not easy to treat someone from the test position you put them in. So that's the big drawback. But if you just want to identify the disorder, a Sidelying test might be a helpful alternative consideration to your Dix-Hallpike.
Because I mean, I was trying to figure out why wouldn't everybody do it? And I hadn't heard of it in regards to, you teach the classics, but the majority of the time what I hear from therapists is, well, they can't lay flat because they can't breathe. I can't get them in this position, and we can't do this in acute. And so, okay, this sounds very promising.
Good. So let me describe how you do a Sidelying test. So if you're going to assess the patient for right-sided posterior canal BPPV, and this can be a little confusing for the learner, is you want to turn the head contralateral to the ear you care about. So if you're going to check the right, you would want to turn the head 45 degrees to the left. All right. And then you maintain that 45 degrees of rotation to the left, and they lie down to their right side. So you got to remember for the Dix-Hallpike test, we turn the head ipsilateral to the ear we're testing and lie flat. But for the Sidelying test, you turn the head contralateral to the canal to the side you're assessing. So for a right Sidelying test, for right posterior canal BPV, you turn the head 45 degrees to the left, and then just simply lie the patient down to their shoulder, not their back. Their
Which shoulder?
right shoulder.
Okay, so head's
Right.
looking up and they come down on the right
Yeah.
shoulder.
So
Okay,
that,
got
the
it.
way you can remember this is when the patient's on their side, their nose is generally facing where your wall meets a ceiling,
Oh,
the
okay.
junction between where the wall meets the ceiling.
Oh, that's perfect.
So
I can
just that's
visualize
where you want
that.
your patient's nose facing. And when they're on their side, their chin should be a little higher than their forehead. No pillow for the test. So if you're doing it on a bed, you would take away their pillows. You could really incorporate this into if you're assessing someone's ADLs, either a PT or an OT, and you're assessing how well they go from sit to Sidelying to sit. You could
Oh,
really just work this into that assessment and just let their head drop back with no pillow, and you can kind of kill two birds with one stone there, where you're assessing their functional mobility, but also watching to see if they get vertiginous when their head is dropped down that far in bed and when they arise. And so you can observe for nystagmus during the test.
actually, that just made me very excited because I was just thinking, if you know this, even if you weren't like going to do it as a test, you're right. Just pay attention to if your
Yes,
patient's complaining of things, while you're just basically getting them out of bed, and then just subtle cues with the head. And you can just, like you said, two birds, one stone. You got to love that.
right. So remember
Okay.
the terminal position should be when they're down on their shoulder, their head should, if I'm on their right shoulder, you're testing the right posterior canal, and the nose should be 45 degrees off a sagittal, well, off a gravitational vector, and their nose should be facing where the wall meets the ceiling with their head cocked back about 20 degrees into extension. So it's 45 degrees rotation, about 20 degrees extension. It's the exact same head position. If we ignore the rest of the body, it's the exact same head position you're in for a right
Oh,
Dix-Hallpike.
yeah. You're
So
right.
the head's going through the same trajectory. It's just the body's in a more comfortable position for a lot of people. You could almost do this. I teach this to physicians and they like it because you can do it with almost without touching the patient.
I got
I'll leave
it.
it at that.
Okay. But hopefully everyone's doing it as you're listening because, okay, right-sided, you're gonna turn the head to the contralateral side to the
Yep.
left, 45 degrees.
Yep.
So then when you come down on the right side, you're looking at the crease between the ceiling and the
You
wall,
got it. And
and with your
watch for
head
nystagmus.
little bit extended because it's matching your BPPV position. Oh my gosh, like,
Yep.
okay, Jeff, even I could do that. That's how good a
Yep.
teacher you are.
Right.
Love it.
So this was first described by Helen Cohen back in 2004. So it was described quite a ways back. And the sensitivity between this test and the Dix-Hallpike seems very comparable. And the head's going through the same trajectory. So the otoconia, which is what causes BPPV, I don't think it cares, where your torso is. It's all about what trajectory are you taking the head through. And it's just an alternative way to do a positioning test. It also works well from personal experience on YMCA gym benches, church pews. If you're in a situation where you're out in the
You're doing
community
this
and
in the
somebody
church.
stops you and says, "I heard you know a lot about dizziness." So I've done it out in the. It's a way to test somebody. You can really test somebody on the ground carefully. These are little off-label uses. Let's
Let's
stick to
be clear.
therapy. That's
We do
somebody
wanna
that
be clear.
make sure you have your hands on the patient's head and splint their head, though. They feel a lot better. When someone's vertiginous, they want firm hands on head. So I wouldn't stand there and watch it with your hands behind your back. Once they get down and you're observing for nystagmus, you probably want to like provide kind of like splint their head so they have confidence with staying there and showing you nystagmus and holding the position long enough for you to assess it.
Well, I'm gonna take advantage of you here, right here, Jeff, because, I don't teach this content when they teach it to the students, but I've had a couple different people, and they've all given different cues of the best way to splint the head.
Yep.
Can I ask what your 2 cents are so when the student
Yeah.
asks me, I'll feel confident?
Sure. So don't compress soft tissue. So no hands on the cheek or in the front of the throat.
Okay?
Your hand should be the ulnar border of your hand should be above patient's earlobes. So high on the patient's skull. The upper part of our skull is really bony and firm. So I like to wrap my hands right around the patient's upper skull, ulnar border of my hand above ears. And I hold the patient firmly
You're like,
that way.
"This?"
Yeah, right,
Okay.
up in that region. Yep.
Okay. Okay, good.
Again, you don't want to compress on the patient's cheeks. This is like
Alright.
the front of the neck's a do not touch zone. You want to compress somebody in the. So I sometimes see therapists having a hand under the
Oh,
neck and one on top of the head. I'm like, you might want to let's switch off to having the hands high on the head, above the ears, and make your hands big. Patients like to be firmly held and splinted when they're spinning. Like that's
yeah.
assuring to them, and they're more likely to comply with your testing procedures when they sense through your hands that security. So
Excellent. Well, that's a A++ on this one. That's
great.
just number 1. So what
Yep.
else do you have?
Okay. So number two, now this would be kind of for the more experienced vestibular therapist. So we'll kind of I think that Sidelying test is really something anybody can start to incorporate into their practice.
I agree.
All right. So there's an emerging form of BPPV. So typically BPV affects what we call the long arm of the canal. And so the long arm of the canal, the debris just kind of migrates within the canal away from what's called the posterior canal cupula. There's also what's called the short arm of the posterior canal, and it sits above the posterior canal cupula and it connects the utricle to the posterior canal cupula. And it's becoming clear that debris can get entrapped in that duct and kind of just lay on your cupula. And the optimal test to identify this, we're learning, is not a full Dix-Hallpike test.
Okay.
It's actually what's called a half Dix-Hallpike. So instead of putting your patient back in a full Dix-Hallpike with their head extended 20 degrees over the horizon, you kind of want to start doing your Dix-Hallpike and just stop halfway back, which is about 60 degrees on your way back. So they're almost like they're back in a recliner, 60 degrees. There's a way
Okay.
to think about it. That's where you want to stop with their torso. Their head's still rotated 45 degrees towards the side you're testing. And what that does is it puts this membrane we term the cupula, which houses your cilia for your posterior canal. It places that complex perpendicular to gravity. So it maximizes gravity's force on it when you have stones entrapped on it. So think
Okay.
about when your cupula's heavy, it's going to bend the most when your cupula's perpendicular to gravity, not parallel with gravity. So if you have weighted stones on your cupula, it's not going to billow much when the complex is aligned with gravity. We want it aligned perpendicular to gravity. And so when the fragments are on top of the cupula in that position, it's going to maximize the displacement of the cilia cupula in that position. And that's where you should see maximal nystagmus for someone that has debris in the short arm of their posterior canal, not in the long arm. So it's a way to identify an atypical variant of BPPV, which will not respond to our modified Epley's maneuver. So there's different treatment approaches for that type of BPV, but it's really important that you recognize that they don't have the classic form of BPV when that test is positive.
Has a half Dix-Hallpike? I've never heard of it. Has that been around for a while? I mean, or is it just because 'cause I'm
Uh,
not a vestibular expert?
so I think it's more popular in the recent literature. The first mention of it, not exactly sure how far that goes back, but definitely in literature over the last 5 years, you see it pretty pervasive within the recent literature.
Very nice. I like it. I will be doing that one, but I like it.
So we'll move on to number 3.
All right. I can't wait.
All right. So you may get a little intimidated by vestibular because you hear that how helpful infrared goggles are. So we use goggles to do a lot of testing procedures on patients, and so we can see their eye better. That's one advantage of the goggles because it's blown up on a video screen. So magnification is an advantage of the goggles. And then the other attribute of the goggles that helps you with seeing peripheral origin vestibular nystagmus is that we can watch what a patient's eye is doing when they're not fixated. That means they can't see you during the examination procedure. They're in complete darkness and you're denying their fixation. So, an important rule for the audience to remember is vestibular origin nystagmus is much stronger when the patient is not fixated, meaning they can't lock their eyes onto something and use their central nervous system to suppress the peripheral origin nystagmus. And so if you don't have goggles, what do you do as an alternative? So an alternative I would suggest to your audiences that we all have is a cell phone. So what you can do with your cell phone. So for example, you're working with a patient and you want to be given an exercise session, whether this is OT or PT, and the patient tells you, I really don't feel up to it. I'm feeling like I'm spinning. So you want to first like assess to see if they have any nystagmus in room light, like with your naked eye. And you could check that with them looking forward, looking right, and looking left. But even a more sensitive way to check them for nystagmus is turn out the lights if you can in your room, cover their one eye, and with the other eye with a very bright flashlight. So you turn on your flashlight app and direct that light to your patient's other eye. So in that situation, dark room, one eye covered, bright light in the other eye, they're in a non fixated state. And it's a lot easier to see vestibular origin nystagmus. So, for example, if your patient's in the midst of a Meniere's related vestibular attack, which are awful, you'll see the nystagmus a lot better if you just do what I just said without any fancy goggles. So, again, dark light, occlude one eye, bright light in the other eye will help maximize your ability to see nystagmus that's of a peripheral origin.
Now, would you do one and then the other?
It's not typically real important when you're looking for vestibular peripheral origin nystagmus to assess each eye, because generally both eyes do the same thing. So if somebody has right beat nystagmus, unless they have a prosthetic eye or an eye muscle injury, or like a
We only need one.
sixth nerve palsy, like we can really get by with just looking at one eye that moves normally. That's why it is important to screen for uh, ocular range of motion before you do a vestibular assessment to make sure both eyes do move a full range and conjugately. And if we've established that, Then when you get to vestibular special tests, you can just focus in on one eye that you know moves normally, which for most humans is either eye, but there are exceptions where you don't want to flash your light in a prosthetic eye. We want that over on the eye that's plugged into the patient's nervous system.
Got you. But I like the reminder, do your ocular motor testing, make sure you know that, then you
Right.
can pick one eye. And then I remember you saying, and even focus on just the blood vessel
Yes. Yep.
of one eye. I remember you saying that in the first episode. So
Correct.
I thought that
Good.
was so
Yep.
smart.
Because that's embedded in the eye. It's going to move with the eye. So if you see that vessel, jumping up and down vertically, there's vertical nystagmus. If it's twisting like the hand on a clock, then they have torsional nystagmus. So it really tells the story. So I'm glad you remembered that.
See, it was so good. And combining that seems doable to me.
Right.
Do they usually close their eye though when you shine it in there, or do you have
Yeah.
to like try and keep it
Um,
open, or they do okay?
sometimes, uh, if you have to, use your other hand to pull their eyelid open. So I'll just go below somebody's brow and pull the lid open as the light's going in if that's an issue. Most patients are compliant with it. If somebody has photophobia, like if they're a migraineur and really sensitive to light, sounds, and odors, they may not handle it as well. There's no known harm in irrigating an eye with abundant light. So, like you may have some diminished visual acuity shortly after it, but there's no long lasting negative consequence of using this method.
We'll just see
That's just
some
an alternative method if you don't have goggles.
spots after. But a lot of people don't have
Right.
goggles, Steph, and I
Yeah.
think, you feel then and then it just seems to me, again, not the vestibular experts per se, but if you don't have goggles and you wanna be as accurate as possible in describing, or if the OT is doing it or the PT is doing whoever, but they're gonna go to someone else to do, other work if you're seeing them in a different type of setting and you want accurate documentation, I think that's a really great suggestion. Okay,
Absolutely.
so we got
And
through
so,
3. Yeah.
remember, if your patient's hypotensive and that's why they're dizzy, you're not going to see any nystagmus, but you've maximized your ability to look for it. And then you can jump to taking a blood pressure, look for other causes. But anytime you're working with a patient and they tell you that they're intensely dizzy, always hawk in and look for nystagmus, and you can maximize your ability to see it by blocking fixation.
No, I love that reminder though, because I think we have to continually search for the why, because if not, then the dizziness, I mean, again, we're saying dizziness because that's what the patient says
Yeah.
generally, feels like it feels overwhelming because I don't know what to do with that. It's, oh,
Right.
well, we're dizzy. And then you just keep moving instead of figuring out the why.
Yes.
So I love that because I think that's a very good strategy for figuring out the why.
Yeah, I found in my experience, a lot of therapists seem to be enthusiastic about treating a patient, but I think sometimes we don't take enough time to figure out what we're treating. I have a lot of patients that have come that have seen other therapists at our center, and I'll ask them, well, what was the conclusion as to why you were dizzy? And the patients don't know what the conclusion was. And then it just sounds like they're trying every treatment known to vestibular. Like they tried maneuvers and they tried gait stability exercises and balance exercises and just sort of a shotgun approach, which was well intended, but I think precision is helpful. And you can have precision when you know why the patient's dizzy in the first place. So I can't emphasize enough how important it is to first figure out diagnosis first, treatment second. You can.
But I love that because we can always make our interventions better the more specific, whether or not it's vestibular. I wholeheartedly agree with that, and I think sometimes it just feels overwhelming, and you get distracted by everything that's going on with the patient. So these kind of little tips are these hidden gems, as you were saying, are just perfect for this. Okay, so you
In
have
acute, just on that last one more thing. If you're in
yeah.
acute care, the most helpful place to do that is to take the patient into the bathroom because you
Uh,
really need a dark room, and there's too much ambient light in a patient's room, especially if
mhm.
they're sharing a room with somebody else, and there's a window with light seeping through. So I actually take them in and I sit them on the toilet, and that's where we will check for nystagmus and do some vestibular procedures, which um, it's really interesting because sometimes you have trouble finding a nurse's aide when you need one, but then when you have 82-year-old Bertha on the toilet and you have a flashlight in her eye and covering her other eye, then the nurse's aide comes in and wonders what you're doing.
So now you found the magic combination to get someone to come help you. But again, another very specific strategy that I don't know if I would have thought of that. I mean, eventually, but oh, I love that. Okay, very nice, very helpful.
All right, so we'll move on our list. And the next one's mastoid vibration. This test has become really, really popular. And this, again, is probably for someone that's doing some vestibular that's listening to this podcast. So we all know that our ears respond to what? So, JJ, if I ask you, what does your ear respond to? Like, what sensory stimulation does your ear react to?
Vibration, right? Isn't it?
You weren't supposed to jump to that.
Oh, well, I was just thinking because that made me think of the ones that you put around that just they go right on the bone, the ear pieces.
Right. Well, let's take a step back.
Okay. I might not know the answer, Jeff. Don't make me look bad.
Sound waves.
Okay.
And our vestibular organ responds to head movement and changes in our head position in relation to gravity. So most people recognize that. But also, interestingly, hair cells in your vestibular, both your semicircular canals and what are called your otoliths, are both reactive to vibratory forces. So not just movement of the head and change of head position in relation to gravity, but there's actually hair cells that react to vibratory forces. And so we could take advantage of this. So in a normal subject, and again, this is when you have fixation blocked. So we're using our video goggles or the flashlight like I just talked about. If you walk up to somebody who has normal vestibular function and you vibrate their mastoid bone, which is right behind your ear, in a normal subject, if you watch eye movements, they either get no response, or if you're vibrating the right, they get just a little weak right beating. And you do it on the left, and they either get nothing or a little bit of weak left beating. That's in a normal subject, what we see. Interestingly, a really reliable sign that your patient has lost vestibular function in one ear is when you vibrate either side of the skull, right or left, they only get nystagmus in one direction, meaning I vibrate their right mastoid and they get left beating. I vibrate their left mastoid and they still get left beating. So no matter what side of the human skull you vibrate, the nystagmus is only driven in one direction. That's an abnormal response with mastoid vibration. And that strongly suggests your patient lost vestibular function on their right. As if you're getting left beating with mastoid vibration on either side of the head, the test takes 30 seconds to do once you're set up. So it doesn't take very long. And whether you lost vestibular function in 1984 or 4 weeks ago, you flunked the test the rest of your life.
Really?
So if you have vestibular hypofunction, it's not something we compensate for over time with this vibratory test. Because what happens with an acute vestibular loss, like if I lose function on my right side, you get abundant left beat nystagmus when it first starts. And then it just, due to central nervous system compensation, as days go by, that fades. And that's nice for the patient because they can start to see well,
Right.
and they don't have oscillopsy any longer. But it's difficult for you, the examiner, because you're losing your sign of what happened. But the nice thing with this mastoid vibration test, it's a lifelong legacy. This abnormality will be of vestibular loss. And it rarely lies about what ear's involved. So if we're getting right beat on both sides, we think left hypofunction. If we're getting left beat on both sides, we're thinking right hypofunction. And it agrees very well with other tests of vestibular function we have to corroborate that. And it's simple and easy. The vibrator needs to vibrate, by the way, at 100 cycles per second, 100 hertz. So if you're going to employ this test, you need to be able to vibrate the skull at 100 cycles per second. So make sure the vibrator you buy does vibrate the skull at 100 cycles per second.
So it's not just where you hit the tuning
Can't do it
fork.
like manually with your hands. You need an apparatus to do it.
No, the one that you hit, I'm just blanking at the name.
Fork.
Tuning fork, and then
Yeah,
you put
not
it.
adequate.
No. Okay.
It's not adequate.
No. So that people know that. Now, do you do that? So is there a specific one that you buy? Does it matter? Or do you
Well,
buy?
I was
I know
going
you
to
can't
stay
promote
away
a
from
product per
commercial.
se, but I'm just saying you can.
If you look, so if you look in a
search.
if you look in a rehab catalog,
Yeah.
make sure I don't want to endorse a specific brand
Right.
to stay neutral, but make sure that when you look at the properties of the vibrator you're buying, that it vibrates at 100 cycles per second. That's what you need to know. So that's the trait you're looking for. Um, I, you won't have to look too far because probably the most common one purchased in the rehab catalog vibrates at 100 cycles per second
Yeah.
on
So
the
just
high
so that you
setting.
know what to search for. Now, do you do that every time?
I do it when
What's your
my concern from a patient's history is
Mhm.
vestibular loss. It's not useful as a test for BPPV. So it's not a test that sorts out whether a patient has BPV or not, but it's a very helpful test for discerning if your patient has vestibular loss, which is really important for the therapist to discern whether your patient has BPPV, treatment maneuvers, very effective for that, or am I working with a patient who's dizzy because they lost vestibular function, which the intervention for that's very different. We do exercises to try to restore balance in their gaze stability. So it's really helpful with group B to discern if you've lost vestibular function. Say you have a patient with a temporal bone fracture, which houses your ear 3 months ago, had a TBI, temporal bone fracture, and you want to know if they lost vestibular function due to that temporal bone fracture, which isn't uncommon. That's a test you could employ to see, did my patient with their TBI and skull fracture, did they lose vestibular function? Don't do it in the acute phase. I said 3 months later. So
But that's really good to know because, I mean, you have someone who has a traumatic brain injury, a PT or OT, and they're trying to figure out why they moving the way they're moving, and they can't express to you that they're dizzy. They can't, cognitively
absolutely.
tell you what's going on, and you're trying to, again, what I loved so much that you said earlier, be more specific so you can identify how to approach that. Then,
I
you know,
think we talked about this
anyone
on
can do it, or either discipline could do it, and then they could just talk to each other.
I think we talked about this on the last episode, but with the patient with TBI or dementia, it's really common for them to have agnosia, which is a higher brain center in awareness of vestibular
That's right.
symptom.
I
So they're
remember that.
suffering from the falls and they can have nausea with their vestibular dizziness, but they're not going to tell you much about it. You can't rely on what they're saying. There was a pretty recent study that looked at just in a falls clinic how common BPPV was, and it was close to 50% of the subjects had BPV, and many of them not complaining of vertigo. So again, we hammered that home. I think last time I was on here with you that you can't. If you just wait for a patient to complain to you of vertigo to think I need to check for BPPV, you're missing a lot of geriatric patients and patients that have had a brain injury.
I'm glad you brought that up, and I get yeah, I would encourage people if you didn't listen to the first one that Jeff gave some really fascinating tips about that. Because again, the comprehensive approach to our patients is so important for us to keep them safe when they go home or they're at home with their family. Keep them off the floor. You can't just work on one like it's standing and then feel like you got their balance, improve their balance. So, those were some of the pieces that I took away from the last one that you talked about. I thought was really helpful.
Very good. I just wanted to last mention there's on the mastoid vibration, there's a free access article. The authors are Alonso and Caletrio, 2024, on PubMed, or so you go to PubMed, put in those authors, put in vibration, vestibular should be the first thing that comes up. And that's a free access article. That's an update on mastoid vibration. It does a
Cool.
nice job of describing the history on the test and what we've learned about it in the last several years. And that's a really helpful article that's free access that the learners could log on to and read.
Yeah, we can put it in the show notes.
Yep, that'd be great.
That's perfect.
All right,
Love
shall we
it.
move on?
Yes, please. Can't wait.
Okay. Next item is something you won't do to the patient as a therapist. But if you
Okay.
know who needs it, it's really, really helpful. So this treatment procedure, so now we're going to talk about treatment because thus far we've really talked about testing procedures, is probably the most helpful thing I see an otologist do to a vestibular patient. And so some patients have a disease called Meniere's disease, which is an awful disease. You lose hearing in one ear over time, you get persistent ringing in your involved ear. And then the most troublesome aspect of the disease is out of nowhere, with no warning, you get attacks of vertigo that most people rate as an 11 out of 10 in severity. with nausea and vomiting. You're disabled while they're happening. It's like being trapped on an amusement park ride. And the average attack lasts 4 hours,
Oh my gosh.
and they're random and they're recurrent, and there's no warning to when you're going to have them. So it's really disruptive to your life because you are completely disabled when you have an attack. Patients very commonly have to lay down or sit down during an attack till it passes. But then in between attacks, patients are pretty functional. It's not responsive to rehabilitative treatment, so we don't really have a rehabilitative treatment to stop vertiginous attacks from Meniere's. So, in subjects who have lost considerable hearing with Meniere's, there's a procedure we do called at our center called gentamicin injections. You might be familiar with gentamicin as an antibiotic. It's an aminoglycoside. Interestingly, it has a property of destructing vestibular hair cells. And so in subjects with Meniere's disease, we inject it into their ear, not because they have an infection, but because we reached a point with them and they have agreed that they need this done where they need their ear turned off. So it's a way to ablate the vestibular function in their diseased ear, and it's very effective at stopping their attacks of vertigo. So it's a way to chemically damage the vestibular hair cells and create a stable vestibular loss, which the patient can compensate for pretty well as long as their other ear is healthy, and restore predictability with their life. It's very effective at stopping attacks, spontaneous attacks of vertigo related to Meniere's. And also, after the procedure's done, then actually the patient's an excellent rehab candidate because they have a stable unilateral vestibular loss. And that's where vestibular compensation exercises can be very helpful. They're not helpful when you don't have a stable loss. And with Meniere's, you have a lot of fluctuant function due to the nature of the disease. So it's a very effective treatment to stop vertiginous attacks from Meniere's.
Okay, I have a couple questions.
Sure.
Because one is, so it, for some reason, the gentamicin back in the day, it's like, oh, when they were on that medication, it killed the hair cells. So then we gave them vestibular issues, and so they, weren't
Right.
using it, and they switched, right?
Yeah. So let
Okay,
me explain that. So, JJ, when patients get IV gentamicin for a life threatening infection, a small number of patients, when you give it IV, not injected into the ear, we're injecting it into the ear. When you
okay.
give it IV, there's a small number of patients that get bilateral vestibular loss from that because the chemical's toxic to your vestibular hair cells. So that can create a vestibular disorder in your patients that's had a life threatening infection on IV gentamicin. But we're
Oh,
using it selectively just to ablate one ear. So it doesn't circulate throughout the whole body. We're just putting it into the ear that we
oh,
want to kill.
this is very exciting because that makes a lot of sense to me. You
Yeah.
really good at explaining that. And so, are there very many? So I just can't imagine feeling that dizzy, um, and just having those attacks come on. So I could. That is just so helpful for people to know. Now, do a lot of doctors do it, or
So you
is it
probably
hard to
just have
find?
your patient see an ENT that just specializes in ear problems, which would be an otologist. So that's an ENT that just has a special interest in mostly ear practice, or a neurotologist. A lot of community-based ENTs wouldn't probably feel comfortable doing that procedure. Um, so I think the patient would have to see an otologist to have that done typically.
Because I sure would want. I mean, as a therapist, you have to feel pretty helpless because, like you said, these attacks
Yes.
are so unpredictable and so
Yeah.
extreme. Like, so to have an option for them to go and explore just seems huge.
Right. And it's usually just we can do it up to 3 times, but the vast majority of patients we see, they just need one injection. So
Oh,
it's pretty
really?
simple. We numb up their eardrum, one injection. They lie on their side, let the drug absorb through what's called the round window, which is a permeable membrane between your middle ear and your inner ear. And it's usually just a one-time treatment. They actually, though, get the vestibular hair cells. It takes a while for them to degenerate. Patients usually feel like they're spinning or substantially more unsteady about 10 days after the injection. So it's not like we inject and boom, they have the vestibular loss. It's a delayed phenomena by like 10 days to 2 weeks. They notice when it kicks in because their balance worsens. And they almost kind of go into an attack, not a severe attack, but usually a milder protracted attack of vertigo. And that's from the hair cells dying. And then we hope that's their last attack.
I got you.
So they go through that protracted episode after the injection, and then we work on compensating, and then we keep our fingers crossed that they're done with attacks because the ear's been deadened.
So for some reason, this is like reminding me of Botox a little bit. You inject nothing right away, and then there is something, but it wears off. Does this wear off, or it's done?
So here's something to know about vestibular hair cells. Once they're dead, they're dead. For humans, they don't regenerate. So once you've killed vestibular hair cells, they don't have a capacity to regrow, which is interesting because in birds they do, but in humans they don't.
Oh,
So
okay.
once they're dead, they're dead.
You're full of fun facts, Jeff.
Well, you asked. One other use for these injections that I think if you're an OT or PT that works with individuals that fall, which is most of us,
Yeah.
keep this in mind. So another use for this is in, again, some subjects with Meniere's late in the disease process, meaning had hearing loss years ago, had vertiginous attacks years ago, which may have gone quiet. Some patients with Meniere's disease get violent drop attacks. They're called vestibular drop attacks. That's the terminology we're using now. They formerly were known as otolithic crisis events of Tumarkin. So these are just random, sporadic, violent falls. I would suggest the podcast listeners, you can go to YouTube or Google video search and put in Tumarkin event, and they have a nice video of a patient having one where they're at work just walking around and bang, they have a drop attack from this is a late stage behavior with Meniere's that doesn't involve spinning. It's a violent dropping episode that occurs in some patients with later stage Meniere's disease. The falls are like you can't stop them, you can't brace them, you don't lose consciousness, so you know you're going down. And they're really violent because when patients have them, their limbs extend. And so their limbs flail out and they don't decelerate their falls. Patients describe them as being kind of like struck by lightning when they have them. And anyhow, these gentamicin injections are very helpful at stopping those also because they're coming from distorted input coming in from the ear. You don't know which way is up briefly. They're very brief episodes, they just last seconds. So they're kind of different than the attacks of vertigo we're talking about with Meniere's. So it's another unfortunate consequence of Meniere's. So they're conscious, violent drop attacks.
Okay. So let me just have a question and then a follow-up.
Yeah.
So, because I could see if you didn't know about that or you didn't check in their history and something like that happened, I would have thought, was that a seizure? Like, did they just, if they're going into full extension and then they're just going down.
Yeah, they don't convulse on the ground.
Okay, so they just go down and they're conscious the whole time. So I'm just saying, if you weren't familiar with the Tumarkin, right, Tumarkin, Tumarkin event, that would catch you off guard, especially the extension thing to me.
It's like
Okay.
their limbs flail and they go down.
Oh, okay. But they go hard like a tree.
It'll turn your stomach to watch that video that I
I'm
just
not
talked to
watching
you about.
that.
Yeah, it's just like boom, they're down. It really looks like someone struck by lightning. It's really a good analogy. That's what patients have told me. We had a patient have one in our hallway at our clinic, and they put a hole through the plaster wall because they just
Oh my
went
gosh.
so violently. So they're commonly injurious falls. What I would tell your listener is, well, you may not know all the diagnostic criteria for Meniere's disease, but maybe try to remember that if you're having somebody that's just having violent falls without any provocation, they're not slipping, it's not misjudgment, it's not due to weakness, it's just violent and sporadic without any warning, ask the patient if they have hearing loss in one ear. Start with that. And then ask the subject, in your younger days, do you remember having bad attacks of vertigo where you had to go to bed and would vomit and everything was spinning for hours? And if you get a yes and a yes to that, then the likelihood of it being of this vestibular drop attacks is higher. So that's kind of a good way to query around it. If you remember, ask the patient if they've ever been diagnosed with Meniere's. But
Absolutely. That's very helpful. Okay. That's
walk,
fascinating. Okay. I did not know that.
walkers, canes, waste of time. They're just in the way of the fall. They won't stop the patient from these sort of attacks. So they're not like we can't prevent them. Could
So it's
pad the
back to the
patient up.
why again. It's back to the why. Because that's so different. It's not like, oh, I'm just losing my balance.
The walker would just be in the way of the fall. So would the cane, wouldn't stop it because it's so
Okay.
violent and uncontrollable. So
That must be so hard.
yes, it is very difficult. The patients are scared to get out of a chair when they have them because they never know when they're going to have those either. There's no lead in. It just boom, they happen. So if you have them on a set of concrete stairs, it could be your last fall. Yeah.
Well,
So
now you're just scaring me. Stop, Jeff. No, but yeah, okay. So, but I think that when people see that, it's a bit overwhelming and you're not sure why. And so I love that so that you know what questions to follow up and ask,
right.
what information to find
Yep.
out, and potential options to look into.
Right. I would really encourage the listener, keep it on your falls checklist.
Okay.
So when you have somebody that's frequently falling, but this is just a small subset of your patient. There's a lot of reasons your patient could be falling, but keep this one in mind because it's actually very treatable. The injections work well to stop them. So, I always tell students, if you're going to miss something that's not treatable because less harm to the patient. Try not to miss something. Try not to miss something that something could be done about. And
Right.
this is an example of a type of fall that's very treatable if it's
All right.
identified.
Okay. All
All
right.
right. I
We
think
have,
our last one.
we might have, yeah, probably.
Okay.
We're looking at our
So the
time,
last
but
one I want to mention to you, I'm really excited about. So this is again a treatment. And so this is only available currently in European countries. There's an intention with the primary manufacturer of this device to have it available in the United States, but it's not available in the States yet, but it's on the doorstep.
something to look
So,
forward to.
yes, something to look forward to.
Okay.
So follow me here. This is a belt that you wear.
Okay.
Um, if you had it on underneath your clothing, no one would know you had it on. All right. So it's not bulky. And it has vibratory tactors in it. All right. And so when the belt's on, and there's 10 tactors in it. So there's 10 vibrators that are separated out, equal angulations around the belt. So if you divide, I think they're 36 degrees apart, if my math is right. So they're spaced out evenly around the circumference of the belt.
Okay.
If you stand and you're aligned with gravity, the belt does nothing. If you start to tilt to your right, so you're starting to drift to your right, the tactors vibrate your torso to make you aware, you're starting to drift right. You might want to do something about that.
Turn on the right side, the direction you're
In the
straight out.
direction you're swaying in, and the stronger the velocity of your sway, that's reflected in the
Intensity.
strength of the vibration you get. So it's not just giving you directionality, but it's also telling you how fast you're swaying in that direction. You're like, well, why would you need that? Well, it's substituting for your vestibular loss.
Hmm.
Patients with vestibular loss start to sway and they're not aware of it. So it's a way to provide an augmented sensory cue about how you're swaying in space. So I start to drift forward, the tactors in the front of the belt vibrate. I start to fall backwards, the tactors in the back of the belt vibrate, and it's providing me an avenue for sway detection. So the primary utility we think for this device, and the preliminary research is promising, is in subjects with bilateral vestibular loss. Some patients that have erosion of vestibular function on both sides. So it's the equivalent of in hearing being deaf, but with balance, just having no balance function in each ear. It's a way to provide that subject with augmented sway detection. Non-invasive. You can take it on, you can put it on, you can take it off. It's not like a shock collar for a dog. It's not
Thank you for
painful.
clarifying that.
Although I thought about that, JJ. I wondered if that would be therapeutic, but I don't know if the hospital's going to go along with that sort of device for patients. But it's not. It's a comfortable stimuli, and really, it's just something you put on and you just start functioning. And I've had a lot of discussions with the PhD that's been involved in devising the device, and it's just something a patient gets used to finding useful for sway detection.
You know, when are they going to get it over here?
I
um,
can't answer that. From the avenues of information I have about it, they're very hopeful that it'll be available within the next year.
Now, I mean, this is kind of a sidebar, but don't you think that could help if you had peripheral neuropathy?
think the same thing, but we don't know yet. But that's
Yeah, I
great
mean,
thinking.
of course, we don't know because they haven't researched that, but, I mean, if you think of the concept,
Yes,
and, I mean, it's
absolutely.
the same you're trying to give like, when we use weighted vests, we're trying to use joint receptors to compensate for what we don't have, and so
Right.
you're always thinking, "What don't I have, but what do I have left, and can I maximize what I have left?"
I don't know why it wouldn't, but it
Yeah,
hasn't been the focus. The
yeah,
focus has been on this as a substitute for vestibular hypofunction, but I would think it could help them too. And we see a lot of patients, for example, that have visual impairment, peripheral neuropathy, and unilateral vestibular loss, and it's a multi-sensory deficit in that patient. So anything you could provide to give them a better idea where they're at in space from a sensory standpoint, I think would be helpful.
yeah, need
Um,
all hands on deck.
yeah, the chief researcher behind it finds that your self-rated balance has to be below 50%. So if you walk up to somebody and say, from 0 to 100, how would you rate your balance? With 100 being perfect and 0 being horrible, the patients that seem to benefit from it the most are those that are like below 50%. So if you rate your balance as like an 80, 90%, you may not find it
Well,
as
you wouldn't need
helpful
it.
as the
Mhm.
lower level perceived balance patients.
Well, that'll be
Um,
fascinating to see how
yeah.
that shakes out and even, like, align it with an ABC scale, or does it align with their confidence
Gait
level?
speed, all that, yeah,
Or do they feel more confident with on even if, maybe it isn't doing as much as
right.
we know, but it makes them more confident, so oh, I
W
can't wait to see that come
yeah.
out.
One thing that was encouraging in their preliminary trial is if patients found it helpful after a 2-week trial, so they tried it for 2 weeks and they're like, "Yes, this helps me, I'd like to keep it." The compliancy with use after 2 years was 70-75%, which is pretty high. I mean, that means a lot to me because you know how AFOs are, as an example. Like, you give somebody the wrong AFO, it quickly turns into a dust collector.
Yes.
Um, so if somebody's still using something over a 2-year period and we have 75% of the group still using it, I think there's pretty clearly some likely benefit that they're experiencing from having it on. It's not a training device, so it's helpful when you have it on, but you take it off and you're back to square one. So I don't want the audience to think of this as so much of a training device. It's just a sensory substitute to help you function. It's like a hearing aid. Hearing aid helps you when it's in to hear. You take it out and you're back to having poor hearing. Same thing with
That's
this
a good
belt.
analogy.
We don't think that there's much carryover when you take it off. So it's helpful when it's on.
Outstanding. Okay, so our time is limited because I was getting all excited about all your great stuff. So, just in regards to, recapping a little bit, like, we keep talking about it could be PT, could be OT, because really, when we're looking at vertigo and functional mobility, I mean, because it's all this transitioning of positions, right? So any of us will be finding this.
Absolutely. I
I mean,
think
because I consider myself not a vestibular expert, and I don't really, but I think that both PT and OT need to have their eyes on it, right? Just in regards to the
absolutely.
vertigo impact on functional mobility.
Yeah. I mean, I think each type of therapist is well positioned to hear vestibular complaints from patients because, in general, patients with vestibular disorders have provocation of symptoms when mobilized. And who does more mobilizing than an OT and a PT with the patient? So I think both entities being very sensitive to these issues is helpful. And there's, BPPV, for example, is commonly triggered during ADLs. You bend down the toilet, you tilt your head back to wash your hair, you bend down to
Absolutely.
tie your shoe, your head's changing its position 90 degrees in relation to gravity, and you're getting all kinds of provocation during those activities that, an OT may pick up on. So,
And I guess I really wanted to emphasize that point because if you see it, don't think it's just a transient. I mean, it might be, but document it and tell each other so you can start looking for trends to identify the why and then taking all
yep,
your great tips into consideration when trying to decide,
yeah,
what to assess or
agree.
where would be a good intervention. Now, Jeff, I know you might not remember because of the first one you did, but generally when you leave here, you make like a one pager with the top 3 actionable takeaways. I good luck with that because you've got a lot of stuff here. So, um, I think that we have this big, long list. I think you've kind of given everybody. I don't know if there's any big heavy hitters you want to just
Yes,
leave
I
us
would
with.
think for the novice vestibular therapist, try to incorporate the Sidelying test into your clinical practice. So, review that, and it's not that difficult to incorporate that into your mobility exam, your functional mobility exam with bed mobility. Um, and for the more experienced therapist, think about using the half Dix-Hallpike. I think all of us can think about using a flashlight to deny fixation to enhance our sensitivity to see vestibular nystagmus. I think that's something we could all do. The Mastoid Vibration Test, again, probably with the more experienced therapist to assess for vestibular hypofunction. And then keep in mind those violent drop attacks from Meniere's and protracted spontaneous attacks of vertigo could be treated with a gentamicin injection with an otologist. It's really important if you get into treating dizziness to establish relationships with an ENT, an audiologist, if you're an OT, a PT, and if you're a PT, an OT. And those relationships are really helpful for optimally managing patients. And then on the treatment horizon is the vibratory belt. Not something you'd have to smuggle it into the country currently.
Not recommending that.
Right. But if you have listeners that are outside the United States, which I
Yeah.
imagine MedBridge does, they may have access to getting the device.
Very cool. Oh my goodness. So great. So Jeff, what we didn't do when you did our first one with us is we were trying to add something like fun at the end, like, oh, come on. So I just want to see what you're going to say. If you could have any superpower, what would it be?
Related to vestibular.
Well, I mean, that's all you kind of think about. So I'm thinking
Right.
that might
Well,
be,
that in sports, but that's a whole nother. Um,
it could be anything though. It doesn't
so
have
a
to be
couple
related to
superpowers I would
vestibular.
like. If I had the power I would like the power to maintain my patient's eyes open status when they're uncomfortable with vertigo, because an ingrained response when patients have vertigo is they want to clench their eyes shut. So I could have the magical power to keep somebody's eyelids propped open without verbally cueing. Because the most common thing I say every day in this clinic where I work is, can you please open your eyes? Got to keep your eyes open. I say that all day. I've thought about getting a recording button that I could just hit every time I say it. In fact, after a while, family members start saying it to their spouse when I'm examining them. They're like, Ethel, keep your eyes open. You're closing your eyes. I'm like, thank you. Thanks for helping me out there.
That's
The other superpower would be an emesis predictor. So he knew when emesis was going to come with a patient. He stopped short of that. And the other thing I would like is the ability to see migrating otoconia in somebody's semicircular canal so I could visualize their BPPV.
you turned a superpower into genie where you got 3 wishes.
All right.
But all right, for you, Jeff, I will give you your 3 wishes. But that
Awesome.
I can honestly say I've never heard I want a superpower for someone to be able to keep their eyelids open. But I only you, Jeff. So that's all our time because we really took every minute. But that's all for today. But just a huge thank you, Jeff. Just really appreciate your expertise and love the practical vestibular tools you can apply in your clinic right away. So thank you for coming.
Thank you. You're always easy to talk to, JJ.
And if you found this episode helpful, please be sure to share it with your colleagues and the first one as well. And thanks for listening, and we'll see you next time. Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.